Great to see you all. So welcome you all. There's a satellite symposiums of TCTAP 2022. Actually, this symposium organized by CVRF and supported by educational grant from Edward Life Science Korea. SAPIEN 3 can drive minimalist TAVI through the economics and patient safety value. All right. I'm very happy and honored to have three distinguished speakers here: David Cohen, David Wood from Canada, and Jung Min An from Asa Medical Center. And I'd like to introduce, Guru Hong Guru, and Dr. Lin Mao Shin from Taiwan, just Sonny Palmer from Australia. So really, thank you for joining us. All right, we want to start first. Lectures from David Cohen, TAVI Economics and Efficiencies, Insights from the First Decade.
Thank you very much, SJ. It's really a pleasure to join you, although I wish we were all together again in Korea, and hope to see everybody there very soon. So my topic today is to discuss TAVI economics and efficiencies, and I want to really review some of the evidence that has emerged over the last decade, the first real decade of commercial TAVR in the United States. These are my disclosures. So why do we care about the efficiency of TAVR? Well, first of all, it's fairly obvious to all of us that TAVR is an expensive technology. In the United States and around the world, the valve currently costs much more than a comparable surgical valve. And for many patients who are now being considered for TAVR intermediate and low risk, the procedures are clearly less expensive for surgical AVR. So we need to think about those costs. There has always been a concern when TAVR was first introduced about whether it's appropriate and worthwhile to prolong life for some of the extreme risk patients. So are we really doing the right thing for these individuals? Is this what they would want? And are there better resources in our society, better uses for these resources in our society? But the real driver in 2022 is that the population of eligible patients for TAVR is large, and it's growing every year. And as a result, even if TAVR is cost effective, which is usually our measure of value, we may not be able to afford it for all patients. So the idea of keeping the cost of the procedures and of the follow-up care down is very critical. So let's first start by looking at a summary of some of the data from the early randomized trials. Back in 2010 and 2011, we were focused on the extreme risk. This is the partner B cohort, where we compared TAVR to medical therapy for inoperable patients. And in this study, we found that TAVR was much more expensive than medical therapy, but it also prolonged life and improved quality of life in a durable fashion. And when we related the difference in cost to the difference in life years or quality adjusted year of life gained, the cost effectiveness was in the intermediate to high value range, establishing that TAVR was a useful and cost-effective technology for these extreme risk patients. Over time, we have continued now down the risk spectrum. The next study that we did was partner A, the very high risk patients. In that study, in the early days, we found that the cost of TAVR was similar to that for surgical AVR in the short as well as in the long run. And there was a very small but statistically significant difference in quality adjusted life years driven by the early quality of life improvement with TAVR compared to surgical AVR. This was a high value technology, again, in these very high risk patients, even in the early days. Next, we move down to a slightly lower but high risk group. This is the core valve high risk trial, where we saw increased costs again, but also a small gain in quality adjusted life years, and again, intermediate to high value. So across each of the three early risk groups, we were in a relatively high value range, but not in a cost saving range. Now, only when we finally moved into the intermediate risk group of patients in the partner 2A trial did we really see the major benefit of TAVR. In this trial, we actually saw much lower costs in the long run, a gain in quality adjusted life years, as well as projected survival. And TAVR for this group of patients, this was the first group that we saw where TAVR was economically dominant. And I think still today, this group, the intermediate risk group of patients, is really the sweet spot for TAVR. These patients derive enough benefit where they feel better and they may even live a little bit longer, and they are healthy enough that they can recover much quicker than the surgical patients. Let's just look at a little bit of the data from the Partner 2A trial, the intermediate risk patients, to see where those findings came from. So this is the randomized trial, 2,000 patients in the United States randomized to TAVR, in this case using the XT valve, second generation valve against surgical AVR. These are the procedural costs, about $20,000 higher with TAVR than surgical AVR, driven largely by the cost of the valve. Over the remainder of the hospitalization, though, the costs were much lower with TAVR than SAVR by about $18,000, driven by a much lower length of stay, about a 5-day reduction in length of stay. Physician costs were also lower, driven by lower costs for anesthesia services and the lower length of stay. And so over the initial hospitalization, that cost difference narrowed considerably down to about $3,000 per patient. So that was the starting good news. The real good news and why intermediate risk TAVR is truly the sweet spot can be seen here in this graph, where we linked these patients to their Medicare data, and we use that to track to see how much Medicare actually spent for the care of these patients over the next 24 months. And what we can see between discharge and 30 days, there were about $3,800 worth of cost savings with TAVR. Between 30 days and 6 months, another $7,000 worth of cost savings. This was driven largely by reductions in hospitalizations and rehabilitation. And then it leveled out between 6 and 12 months, just a small difference. And again, a small difference between 12 and 24 months. But really in those first 6 months, major cost savings. And in fact, if we looked at the 2-year follow-up costs, excluding the initial hospitalization, they were about $9,300 less with TAVR than surgical AVR. And so when we added the initial hospitalization costs to the follow-up costs, we can see that TAVR was actually cost saving this group by about $6,400. Again, a very remarkable finding for a technology that is expensive as the TAVR valve. Where things really start to look kind of very impressive, though, is when we look at it in terms of cost effectiveness. So now what we are looking at is the projected lifetime difference in costs and difference in quality adjusted life years. Quality adjusted life years is here on the x-axis, the cost difference is here on the y-axis, and what you can see is the vast majority of the points, the vast majority of this distribution is in this lower right-hand quadrant where we're saving money and we are extending or improving the quality of life. And in fact, if we look at the central estimate, the main point estimate, we see that over a lifetime, we projected about $8,000 per patient in cost savings and a gain in quality adjusted life years of about 0.15 years. And if we superimpose a cost effectiveness threshold that is viewed as highly cost effective in the United States, $50,000 per quality adjusted year of life gained, you see something really remarkable, which is every single one of these yellow dots is below and to the right of this line, indicating that we are 100% confident on the basis of the Partner 2A trial that TAVR is going to be cost effective compared with SAVR. And in fact, it's economically dominant in this lower right-hand quadrant where we are saving money and saving lives in 84% of patients. So this, again, is a really remarkable finding and is why I think that TAVR in intermediate risk patients, that's really the sweet spot for TAVR. But the question for the next decade is, can we do even better? And this is really where the minimalist approach comes in. In order to understand this a little bit, again, we go back to some of the early work that we did looking at the cost of different complications that are associated with TAVR. This is data from the Partner 1 trials, the Partner and the early Partner 2 trials, and you can see the cost for the different complications, and they are very expensive. Renal failure after TAVR, about $68,000, major bleeding, $32,000, a major stroke adds about $16,000 to the cost of the hospitalization. But what I really wanted to do with this, with this study was to take these cost of complications and multiply them by the frequency of the complications seen in the early studies. And then we can understand what we call the attributable cost. How much are these complications adding to the cost of each patient? And you can see that the biggest driver in terms of complications was actually major bleeding. That was the biggest contributor to the cost for our patients. And arrhythmia, in particular, the need for pacemakers, was the second biggest driver. And so when we look at all of the data from the early TAVR trials and look at what is driving the cost of TAVR, well, the valve is obviously very expensive, over $30,000 per patient in the United States. The total of the complications was another $11,000. But what I really want to draw your attention to is this everything else. So complications are really accounting for about 24% of the non-implant related costs. So that's a substantial opportunity for savings by reducing complications. But the real opportunity for saving costs with TAVR is this everything else. And this is where efficiency comes in, because in these early experience with TAVR, we had an 8-day length of stay. We know we can do much better than that. And so with that in mind, we recently performed an economic study alongside of the 3M trial, and David Wood is going to be speaking about the 3M clinical results and really what the pathway is. What I'm going to show you is the economic impact of the 3M pathway. And what we did here, because 3M did not have a control group, we used the Partner 2 trial, in particular, the SAPIEN 3 valve component of the Partner 2 trial as a comparator. And so in the 3M trial, there were 411 patients, and in the S3I registry, there were 1,077 patients. We excluded the non-transfemoral patients, and we excluded patients who couldn't be linked with Medicare, leaving us with 728 in the registry. And then we propensity matched them with the 3M group to come up with 351 patients in each group. And then we compared the costs over the first 30 days of the 3M patients with the S3I patients. So here is the initial hospitalization. We saw that in 3M with the minimalist approach, the procedures were shorter, both skin to skin and total room time. The length of stays were shortened by about a little over 2 days. And this resulted in substantial cost savings comparing the 3M to the SAPIEN 3 intermediate risk registry, driven by reductions in all the different components of cost, the procedural cost, but most importantly, the post-procedure costs, so that we had about $10,000 worth of cost savings comparing 3M to the SAPIEN 3 intermediate risk registry. One of the big questions that was left about the minimalist TAVR approach is whether there was a catch-up. Were we sending these patients home too quickly? And so we followed the patients over the next 30 days to see what happened in terms of resource utilization. You can see them here. There were really no differences in rehospitalizations, hospital days during the early follow-up, and there was actually a significant reduction in the number of rehabilitation and skilled nursing facility days with the 3M pathway. So as a result, the follow-up costs over the next 30 days were virtually identical between the two groups. And so when we add these together, here is the cost of the initial hospitalization, $10,000 less with the minimalist pathway. Over the 30-day follow-up, no real difference. And the total cost difference over the first 30 days of care was a savings of $11,000 per patient with the minimalist approach. And so if we now sort of look at this together with the data from the Partner 2A trial, what we see here, this is the cost that we observed in the Partner 2A SAVR group, the surgical AVR group. And as I already explained, there was about $9,000 worth of cost savings over the first 6 months, comparing TAVR in the SAPIEN 3 registry to that. But then we add on top of that the additional $11,000 worth of savings that we saw in 3M compared to S3I, and we would estimate we're saving about $20,000 per patient in this intermediate risk group with TAVR compared to surgical AVR every time we use a minimalist pathway. And finally, we just recently have a publication by my colleague and my former mentee, Dr. Suzanne Barron, who just published this earlier this month in Circ Interventions, looking at Medicare data, looking at the one-year costs across different risk spectra in the real world. There were about 10,000 patients in the data set who were treated with TAVR or SAVR between 2016 and 2018, and she risk stratified them according to something called the Hospital Frailty Risk Score, which you can think of as sort of a marker of surgical risk, and which you can see here, whether they were low risk, whether they were intermediate risk, or whether they were high risk, there were substantial cost savings over the one-year follow-up period with TAVR compared with surgical AVR. The in-hospital cost savings, shown here in light blue, were greatest by far for the high-risk patients, but the follow-up cost savings were actually greatest for the low-risk patients. So we had two complementary effects leading to cost savings across the risk spectrum for these patients. So just a couple of final thoughts. I think it's fairly obvious to all of us who've been involved in TAVR that the first decade of TAVR really has witnessed remarkable improvements in both clinical and economic outcomes. It's quite amazing to see how far we have come. And with these improvements, TAVR has matured from what was originally a risky and very costly procedure that really would be reserved only for the highest risk patients to one that seems to save both money and lives for the majority of patients with severe aortic stenosis, at least in the United States healthcare system. Now, this may differ across different healthcare environments, and we can discuss that at the end of the session. In the future, as we move more and more to low-risk patients, acceptability of TAVR for the low-risk patients is almost certainly going to require demonstration of both short and long-term cost savings compared with surgical AVR, because it's unlikely we're going to save lives compared to surgery with TAVR. And in most environments, I believe that a minimalist approach, and probably the extreme minimalist approach, will be a key component of this effort in order to offset the cost of the TAVR valve. Thank you very much for your time.
Great talk, David. Actually, we have discussion time in the later three lectures finished. So next talk, David Wood, he will give us how are we handling TAVI patient journeys from admission to discharge. Okay. David Wood, okay.
Thank you very much, SJ. It's always a pleasure to go after Dave Cohen, and the economic analysis is absolutely compelling, especially as we move into the low-risk patients, which is the theme for today. So I've been asked by TCTAP to talk about the TAVI patient journey from admission to discharge. So first, a little bit of background, my disclosures. There's a picture of Vancouver, and I sure hope that all of the panelists and all of the people attending TCTAP can come and join us on the West Coast later this year or next year so that we can all resume our in-person. Obviously, would love to be there in person with you. So I'll start with Benchmark, and Benchmark is really just evidence-based TAVI care, pre, peri, and post TAVI care, a little bit on the patient journey. Then I'll talk a little bit about the wonderful experience partnering with the Asan Medical Center as one of the Benchmark flagship sites. Dave has already talked about the economic analysis, and then John Min's going to talk a bit about safety when I'm done. And then a little bit here, and this is more me going a little off topic, but not too much, about how this initial patient journey is crucial for future success now that we're talking about lifetime management. And then I know the questions will be deferred till the end. So Benchmark, what is Benchmark? So there's three pieces. We obviously got several hundred patients together at small, medium, and large sites over the last 6-7 years. We prospectively enrolled patients and showed that for the vast majority of patients, they can be done with a minimalist approach, both in the screening piece, the preparation for patients and family on what to expect, that it was going to be a short procedure with early mobilization and discharge either the same day or the next day. So we published the 3M study, we published the quality of life data, which I think is incredibly important and shows that these patients return to beyond their baseline quality of life almost immediately. And finally, then the cost savings piece, which Dave just talked about. So what is the Benchmark program? So it's multidisciplinary. So it's not just clinicians, it's all of allied healthcare working together to improve patient outcomes. And this is key, based on clinical evidence, both the 3M TAVR trial as well as FAST TAVI in Europe. So you can see patient access, the pathway, and clinical outcomes. Historical practices, where traditionally we kind of moved from a surgical mentality to the operating room, general anesthetic, TE guidance, critical care stays of 1 to 2 days, and target lengths of stays of 3 to 5 days, have really melted away. And I'll show you some data working with over 200 centers around the world now implementing this 3M Benchmark approach. And obviously there's a tremendous number of publications beyond just 3M and FAST TAVI showing the safety and efficacy of this minimalist approach. What we did in Vancouver with John Webb and Janar Sadhanathan and others was basically did exactly what anyone listening to this satellite symposium can do, came up with 14 best practices: pre-procedure, peri-procedure, and post-procedure. Over the last 5 years, as I said, we've worked with more than 200 centers around the world, and we learn as much from the centers as they learn from the Benchmark program, and that is certainly true with the Asan group. Typically, when we work with a center, they go through and they look at their outcomes, and they decide who is going to be part of the Benchmark team, whether it's the TAVR coordinator, the VACC, the interventional cardiologist, administration, the implanting physicians, surgeons, interventional cardiologists, the echocardiographer, and all the nursing staff. And then they look at their outcomes. And here, These are the type of outcomes that have been achieved not only in the studies, but I would argue now all around the world, regardless of whether you're doing inpatients or outpatients. Most centers do between 15 and 17% inpatients, regardless of age, because invariably when we first talk to a new region, they always like to say that their patients are sicker, have more comorbidities. But in general, with the average TAVR or TAVI patient around the world, you can achieve a 30-day mortality and stroke of 1%, 1.5% for vascular complications, a pacemaker rate, specifically with balloon expandable, short frame valve, of only 6%, readmissions under 5%, and next day discharge of greater than 80%. And this is key too, to Dave Cohen's point, more than 90% of patients going home within 48 hours. So 80% within 1 day and 90% within 2 days. And we also have a manuscript coming out with 7 of the benchmark sites in JACC shortly that will detail JACC intervention, same day discharge in a small percentage, 5% of patients, and how that is safe and you can achieve similar metrics. So what is happening with this type of a streamlined pre, peri, and post-procedural approach? Because as we're going to hear in the next talk, safety is paramount. If you're doing a low-risk TAVI patient, it is unacceptable to have a complication, or if you do have a complication, you need to be able to deal with it immediately and have an excellent outcome. As working with, again, Son Medical Center, we've learned that the difference between an amazing center and a good center is the ability to handle complications and still have excellent patient outcomes. So in the US, we've worked with 73 centers, tremendous teamwork and collaboration. Outside US, we've worked with more than 100 centers. It's actually more than that now. And 28 centers enrolled in a prospective registry throughout Europe. And again, this is a testament to the wonderful collaboration amongst all of these different countries. I think we're in more than 40 countries now around the world. Obviously, recent events are troubling, but it's exciting to know that we have partners who are committed to patient care. If you look at the snapshot in the US, those are all the different sites in the United States that are doing the benchmark program. And here, if you do a snapshot of Europe, those are just some of the sites in Europe that are doing the benchmark program. And here's this prospective registry. We've already enrolled over 504 patients in the retrospective phase and 226 of 1,500 patients in the prospective phase. Again, using this minimalist, streamlined pre, peri, and post-procedural pathway to achieve those outcomes, 1%, 1%, 1.5, 80% next day discharge with a very low pacemaker and readmission rate. So moving into the final piece here, I would argue that this initial patient journey, choosing the right platform for the right patient, looking at the root anatomy, planning for the second THV and THV is crucial. And we're adding this into kind of benchmark 2.0 is how to calculate this. We know that by 2032, we're going to be doing 30 to 50,000 transcatheter valve and transcatheter valve procedures. And it's not enough just to put a valve in the first time when they're 72. We need to know when they come back at 82 or 84 that we can put in a second valve, and perhaps in rare cases, a third valve, although that will obviously be much less common. And so in Vancouver, working with many of the benchmark sites around the world, we have 2 large trials looking at concomitant coronary disease and also the importance of getting very accurate hemodynamics during that first peri-procedural implantation. And so that's the complete TAVR study and the discordance TAVR study. Briefly, complete TAVR with some wonderful co-investigators, currently only in North America, but working hard with Edwards to reach out to strategic centers like this one to include some of our outside US colleagues. We're basically enrolling 4,000 patients. And I guess the key point from this slide, because it's published elsewhere, is for all 4,000 patients undergoing TAVI, all of them have invasive hemodynamics with an on-table echo. They're then randomized. And if at any time, they're randomized obviously to whether they have their coronaries revascularized or not, if at any time they have either symptoms or elevated gradients, they're brought back for an echo and invasive hemodynamics. We did a similar thing with discordance TAVR. We showed the pilot study at London Valve with Amar Abbas, my co-PI, on behalf of John Webb and Marty Leon and others. Here, we looked at 13 patients. We're now doing a 15-patient study, anywhere from 3 months to 10 years post-initial TAVI, looking at what happens with the invasive and echocardiographic gradients. And again, tying this back into the topic for today, putting the best possible valve in that allows coronary access, that it gives you the best possible gradients, both now and with a possible repeat THV and THV in the future, I think is part of this initial patient journey. And these are just some of the outcomes and how it changed. So conclusions, benchmark in the patient journey. It's really a quality improvement program designed to align the heart team with current minimalist TAVR techniques. And these are constantly changing. So benchmark is constantly changing, and it's aligned with best clinical evidence. We want to partner with the leading centers around the world to distribute this information in a hub and spoke model. One example is obviously our recent work with the Asan Medical Center. The economic analysis, Dave already did a wonderful job. We're about to hear on safety from Jung Ming. And finally, the patient journey, it's not enough just to talk about now. We must look at the future, and studies like Complete TAVR, Discordance TAVR, obviously the SMART trial, others are going to give us information on how to improve that first patient journey so that the second patient journey is superior. So thank you from Vancouver, and I look forward to the next talk and the discussion at the end. Thank you so much, my friends.
Great, David. Thank you. All right, next talk is Dr. Jung Min from Asan Medical Center. Can minimalist TAVI also maximize the safety? Dr. Ang, please.
My topic is, can minimalist TAVI also maximize safety? I'd like to share our center's experience. What is the current TAVR status? The after low risk TAVR, successful after low risk TAVR randomized trial, serial successful randomized trial. So in ACC 2019, low risk was approved by the US FDA. So 2020, 2021, US and ESC guideline endorsed TAVR as a class 1 indication in the older age, regardless of surgical risk. So the TAVR has become a routine procedure in many cath labs around the world. So what is our status, our TAVR program? The last year we did more than 200 cases per year. So far we've done more than 1,000 TAVI procedures. We predominantly implanted SAPIEN 3, 71% among the 1,000 TAVR cases. So among the 1,000 patients, the mean age is 80, ST score is 4, some comorbidities. The device success rate is 99.1%. Conversion to surgery is only 1.4%. Permanent pacemaker implantation rate is 7.4%. More than moderate PVL is 3.9%. The length of stay in overall patient 7 days. So permanent pacemaker implantation rate in the SAPIEN 3 population is around 7%. 30-day outcomes in our centers, the death is 1.8%, stroke rate is 2.7%, death or disabling stroke is 2.7%, bleeding, life-threatening bleeding is 4.6%. So 30-day outcomes in 2020, 164 patients we analyzed. 1 month death is only 0.6%, stroke is 1.2%, death and disabling stroke is 1.2%, permanent pacemaker is 6.6%. So in 2002, the 30-day mortality dramatically improved. 1 year outcome is like this. Overall patient death is 7.5 at 1 year, stroke is 4.4, the rehospitalization is 22.6%. This is a summary. Overall population, one month mortality is 1.8, but 2020, 1 month mortality is 0.6, major stroke is 0.6, no vascular complication, pacemaker implantation is 6.6, moderate to severe PVL is 1.8. So what is difference in our Asan Medical Center? We have a perfect heart team. We have good collaboration with the surgeons. In addition, we applied the contemporary minimalist approach since several years ago. In addition, very effective CT algorithm for pre-planning would work very well. What is a minimalist approach in Asan Medical Centers? No general anesthesia, no TE, and 30-minute procedure, no urinary catheters, only 1 day stay in CCU, discharges on day 3, and cardiac rehabilitation program. This is our routine practice when we met the patient outpatient clinic and admission Monday, Sunday. We evaluated the CT and other evaluation on Monday, Tuesday, perform TAVR and Wednesday, and discharge the Friday. This is our routine practice in 2022. Recently, TAVR length of stay, TAVR hospital length of stay is getting shorter. Even same-day discharge is suggested in the COVID era, but in Korea, same-day, very early discharge not performed yet because in generally, the admission cost and hospitalization cost is very low in Korea compared with the device cost. So instead, we target for discharging is the post TAVR day 2. So day 1 day stay at the CCU, day 2 transfer to the general ward and cardiac rehabilitation. Then day 2, we try to discharge patient back to home. So several years ago, we started the minimalist approach. The 2019, more than 90% of TAVR was done by the minimalist approach. So this is the data between the before minimalist approach and after minimalist approach. Mean age is a little bit higher in the minimalist approach. So this is the procedural characteristics. Bicuspid is 11%, mostly done by the balloon expandable device, 88.7%. This is procedural outcomes after minimalist approach. Device success rate is 99.9%. Conversion to surgery is very low, 0.9%. Pacemaker implantation rate is 6.3. The moderate and severe PVA is 2.1. Major vascular complication is 1.8. The overall length of hospitalization is less than 1 week, significantly reduced compared with the previous length of hospitalization is around 10 days. This is 30-day outcomes. Overall mortality at 30 days is 1.0. Stroke rate is 2.2. Among them, the disabling stroke is only 0.7. Death or disabling stroke is only 1.7. Life-threatening bleeding is only 2.6. This is the safety concern of safety aspect of our minimalist approach. Compared with the overall cohort, the after minimalist approach, overall mortality at 1 month is only 1.0. Major stroke is 0.7. Vascular complication is 0.8. Pacemaker implantation rate is only 6.3. Moderate to severe PVA rate 2.1. It's very similar to the benchmarker, the outcomes mentioned by the Dr. Wood before. So this is my final talk. Careful patient selection, dedicated procedural technique, and post-procedural care are keys to success. Minimalist TAVR, if done appropriately, can maximize clinical and economic benefits. Thank you for your attention.
Okay, these 3 consecutive talks we're talking about cost benefit, economics, and minimalist TAVI approach. So, right, you want to have some comment and discussion times, Dr. Hong? Ready?
Yes, I'm Guru Hong from Severance Hospital, and great to meet all of the speakers and Professor Park and An. Basically, I'm not interventionist. I'm imaging and echo cardiologist. So I want to ask that Professor Cohen, Dr. Cohen, you mentioned about have a benefit, economical benefit versus TAVR procedure, but in Korea, it's quite different situation compared with in the United States healthcare system, because TAVR in Korea, TAVR is much cheaper than TAVR procedure. If you are in the Korea, you should pay about $5,000 for the SAVR and $30,000 for TAVR. In the low risk patient is less than, in the patient age is about 72, so it's a low risk. So what do you want to perform the in this kind of situation?
Well, if I were the patient, I would still want the TAVR, but if I was paying for it, I might feel a bit differently if I was the government. I think that is that's what I mentioned towards the end, is that the analysis we've done is really specific to the United States healthcare system, where costs of hospital days are much higher than they are in Korea. And so especially days after surgery, ICU days are several $1,000s, $2,000 to $3,000 per day. And so reducing the length of stay by 5, 6, 7 days can almost pay for the valve. And then we see these large cost savings actually during follow-up. Let me ask you a question, because I don't know. I mean, I've seen, and done TAVR procedures with Jungmin and SJ and in Korea, but I don't know what happens to the patients after they go home. In the United States, after surgery, many of our patients don't go straight home. They go to a rehabilitation hospital or go to a nursing home where they may spend a week or two. And we saw, again, in particular in the intermediate risk patients, the patients with an STS score of 3 to 7%, there were major savings there. Even we just presented earlier this last year at TCT, the low risk TAVR patients, and there we saw savings as well with respect to the after discharge. But what happens in Korea especially to the surgical patients? Do they go home or do they go somewhere else after their hospital stay?
Usually they stayed in the 7 days. After operation, they usually stay in the 7 days and after go home. And even after surgery, they have a pain, and there are some limitations for quality of life. But most of patients, the low risk is about age of the 60s or 70s. They are good.
Yeah, most of them go home. Yeah, I think that, I mean, even in the low risk trial in the United States, the majority of low risk patients after surgery went home, but still about 20% of them either went home with nursing services or went to a rehab hospital, and only about 2 to 3% of the patients treated with TAVR went home. So, but I think you are correct that the equation for where cost savings occurs is different in different countries. Right. And I think and it really where TAVR saves money is readmissions, rehabilitation, in the hospital days. And if those are not very expensive, then we won't necessarily save money with TAVR, but we do save, improved quality of life, which patients very much appreciate. We've studied that, in great detail, and that's a very critical factor. And in some of the higher risk patients, we may even save lives. I think we probably do. Not in the low risk patients. I think we will not. So in Korea, probably the answer is eventually the valve prices are going to need to come down if you want to be able to afford to do TAVR in all of the low risk patients. You can't afford $30,000 for every TAVR because the other resources are not as expensive. So I think it's a very perceptive question, and one that needs exploring with your own data.
And
I just add something into what Dave said, because this is absolutely crucial and maybe wasn't highlighted. Excellent question. Although the theme of minimalist TAVR is universal, it's obviously depends on the local context. So we worked with Hassan. We saw your amazing periprocedural outcomes. You're already beating all of those numbers, or the team is there. But then part of it is obviously mobilization and length of stay, which can happen with reimbursement. We know in Germany, they can never go below 4 days, or currently they wouldn't get full reimbursement for their procedure. But going from 13 days to 4 days was still a huge piece. You've got Sunny on the panel here. We worked with you. You're the first benchmark certified site in Australia. There was different hurdles, right, about showing your local group just what was possible with minimalist TAVI. So I think it's an incredibly important point that although the concepts are universal, it really does apply to your region to make it work for your patients and your system. Sorry, thanks.
Okay, Dr. Lin. All right, great.
Yeah, thanks for three excellent speakers to have. I'm learning a lot from your lectures. I want to deliver an issue about do we need to have a routine, have a pre-procedure another admission for the cardiac cath, because I know that still in for also especially for a cost-effective issue, because I know it's still in a lot of center in a lot of country that they still there the patient have another admission before the TAVR and do the cardiac cath. But now it's not our routine because we only do the decision depend on patient's TAVR MDCT result. So what's your practice in the US, Canada, and Australia or in Korea for this such issue?
So if I may, and then I love to hear from other people, it is incredibly variable. I've spent way too much time on Zooms for the last couple of years. We used to be able to go and we'd share a meal with you, maybe a drink, and spend time in all these wonderful countries around the world. But it is very interesting how much people have pulled away the screening during the pandemic. So some regions of the world have gone completely to cardiac CT, and that's it. And a virtual assessment with the patient. Sometimes the patient virtually joins the heart team meeting, and that is the whole process. Others, an angiogram, a CT, the echo, all done. They come in and meet the patient. Not too many are admitting patients for that, but it's a kind of a package piece. But it really depends where you are in the world. I think if you ask me the general gestalt, US, outside US, everyone is moving to a more streamlined pre-procedural piece. The idea of getting a dental appointment and having pulmonary function tests, that really has disappeared the last couple of years. But please, others, comments. I apologize.
Great. Sonny?
Yeah, our approach here in Australian Settling in our unit, we've got increasingly more streamlined where we're bringing the patient in. They do have a coronary angiogram at the moment, but we're exploring CT also. So they'll have their coronary angiogram the day before, see us in the clinic, and their echo that day, see us in the clinic the following day, and then also have a CT on that day. So we have a lot of regional people, so people maybe 4 hours away. They come in over a 2-day period. They get everything in hospital. We used to bring these patients in and admit them overnight. Many of those patients now are staying in the hotels locally around the institution to take bed pressure off the hospitals, particularly as COVID ramped up here recently. So it's gone very, very much streamlined. One thing we do not mandate, but we think visually assessing the patient and having that face-to-face contact is very important with the patient and their family members, because that builds that rapport. And so when you're informing these patients they'll be going home the next day, I feel that if you have a face-to-face visit, they're more comfortable with that as opposed to being over a Zoom or a virtual space. So that's our approach, and it's worked very, very effectively. And like I said, we have a lot of regional patients from the country.
I think in the US, I can't generalize. I've only practiced TAVR in 2 institutions. My former institution at the Mid-America Heart Institute, and now at St. Francis Hospital. And it's very similar at those 2. And the focus is really on making sure that the day of the TAVR goes as smoothly as possible in order to maximize the number of procedures we can do in the day. Before we get started, I was saying that right now at St. Francis, we do about 500 TAVRs a year. And that means that every Wednesday we do 8 TAVRs in 2 rooms, and so anything that slows that down is a problem. And so as a result of that, we tend to, do most of the work upstream. So the patients will come in, they will get their echocardiogram and their CT on the same day that we see them in clinic. And we have a discussion about the, most appropriate management for their aortic stenosis at that point. They will then have an outpatient cardiac catheterization separately within a week or so, and then only after all of that, they may get revascularized or not, depending on what's appropriate. And then the day of the procedure, there is no muss, no fuss. We are just focused on getting the valve in safely, getting the valve in as well and expeditiously as possible, getting the patient out and ambulating as quickly as possible. So I've heard about places that will, for CTs that look very favorable, they will just, do a 2-shot coronary angiogram right at the same time of the TAVR procedure. We don't do that because we want to make sure we're just focused on the TAVR and do that very, very expeditiously. But as David said, I think there is a lot of room for variability in that, given the local environment, what's more available, cath lab rooms versus OR rooms versus clinic rooms. All of those different things may influence how you can how you can streamline the workup.
And just to follow up on that to SJ and others, I think if we put on our future hats, both for coronary and structural, our number of diagnostic coronary angiograms is going to go down dramatically as CT becomes the predominant gatekeeper. 5 years from now, instead of doing 1 in 3 patients for PCI, it'll be 60%. And for structural, I agree with you, Dave, because I mean, you've been part of 3M since the very beginning and now Benchmark. We got very good at doing 5 patients between 7:30 and 5 in the afternoon, or 6 patients. But I think if we put our future hats on, in addition to doing more PCI stenting for the coronary patients, we're really going to get to a place where we're just going to be mixing in aortic, mitral, and tricuspid cases on all of our boards, whether that's a hybrid OR and cath lab. And I look forward to that because it's going to be such an exciting, amazing place to work with us and our trainees and everyone, where you do a TAVI and then you do a complex coronary and then you do a mitral. You know, it's really going to be quite remarkable. It's very exciting.
No, I think, and the key to being able to do that, of course, is eliminating the entire need for any anesthesiologist to be present during the procedure, because the anesthesiologist is not part of a coronary, interventional procedure, but they are, currently in the United States. Even when we do Minimalist, they are very often part of the, part of the procedure, just being there because there might be one case that's a general anesthesia case that day. It's a complicated mix. And so what we learned from 3M is we can get rid of them entirely, and just, work with very minimalist anesthesia. And that's going to be the key to interspersing a TAVR here and a coronary there and a mitral clip done with, with ICE guidance or something like that, in the next room.
Or we just need anesthesia to also reimagine their workflow so that they can work with us in a much more streamlined, amazing way. And I think rather than completely uncoupling, I think that would be best for patients, is that we would have a different model for minimal procedural sedation. But yeah.
You're always the optimist. Always the optimist.
Great. All right. Jungmin, you've shown clearly the data as our, AMC experience. And so I would ask some, you've shown after the minimalist approach is, total clinical outcome is, getting better, even in the, death and pulmonary pacemaker, et cetera. And so, could you tell us exactly the reason why? And as we have some experience, and early experience, late experience, but you can clearly define what is most, important impact for, good clinical outcomes after the minimalist approach. So I would say, just David mentioned about, pre-procedural evaluation such as the CT algorithm, etc. We can talk. You can talk. And so
thank you very much. The very important question. I think 2 aspects is very important. The first thing is on the top of accumulating the experience. I think the CT planning before procedure is the most important things to improve the clinical outcomes. So we have a dedicated CT evaluation team. So before procedure, we made all decisions based on the CT data. So it makes our procedure more stratified and simplified. So it reduced the procedural time and overall the length of hospitalization. So CT planning, sophisticated CT planning is one of the most important things. And second thing is accumulating the experience. So I would like to say that how minimal we have to apply in the TAVI program, I think it totally depends on how good heart team and how good the CT evaluation personnel, and we have to adjust it by the local experience. It is similar to I think it is similar to our left main stenting cases. SJ is the father of left main stenting, as you know. So initially, the patient stayed in the CCU 1 day after left main stenting. But nowadays, we perform the left main stenting at the outpatient clinic basis. So we know how to do, we know how to do appropriately. So I think the accumulating experience and good city planning makes our procedure better and better. So more simplified and straightforward.
I would add a couple of points to that, just based on, because I think it's a hard area to study. We actually are doing a large study in the TVT registry, our national registry now, to try to identify which factors are making patients do better, go home quicker, have more rapid recovery and better survival. That work is ongoing, but there are at least a couple of things that we can say for sure. We actually studied this a couple of years ago with respect to general anesthesia, and we thought when we were getting rid of general anesthesia and going to minimalist and conscious sedation that this was just a matter of convenience, and it was interesting that we could do it. But we actually showed in a very nice study from TVT in about 90,000 patients that avoidance of general anesthesia actually saves lives in these patients. These patients are old, and they don't, even though they usually tolerate anesthesia, every once in a while a patient will have postoperative delirium, and that can be problematic. They again will get from the TEE, they will get a GI bleed. All of these little things add up in these sick patients to excess mortality. So getting rid of general anesthesia is not just a matter of saving money and getting rid of the anesthesiologist. It really is a matter of saving lives. The other one that is the huge factor has been the device profile and our increased ability to do transfemoral in almost everybody, because transfemoral is unquestionably the safest way to do a TAVR. There still is a small percentage of alternative access, and we're getting better at different types of alternative access, but the ability to do transfemoral TAVR really has shortened the length of stay, tremendously, improved outcomes, both quality of life and survival for our patients. And so I think both of those things are really critical beyond the ones that Jung-Min also already mentioned.
Okay. All right. Dr. Hong, please.
Yes. I know that minimalist TAVR is all the rage in the worldwide. In our hospital, 90% of the TAVR procedures performed by the minimalist TAVR. So, but in echo perspective, so transthoracic echo during TAVR is really difficult, has some limitations because of the supine position and poor windows and the radiation problems, and difficult to evaluate the paravalvular leakage and the limitation of the continuous monitoring. So I'd like to ask the interventionist, do we have any selection criteria in the general anesthesia versus minimalist TAVR? If you have, usually you recommend what kind of the patient. For me, we usually performing general anesthesia in the high-risk patient. So in Dr. An's data, compare with minimalist and the general anesthesia, I think there is some selection bias. In the general anesthesia patient is more, serious or very high risk and have a higher risk of using the contrast media, so etc. So Dr. Cohen, Dr. Wood, and Dr. An, do we have any selection criteria for the which modalities, minimalist versus the general?
So I just want to address the issue you raised about selection bias, because it absolutely is true that patients are selected specifically for general anesthesia versus not. The study that we did, that we published, was a very interesting methodology called an instrumental variable analysis. And what this does, actually, it takes advantage of the fact that in the United States, there were many centers that were doing a lot of conscious sedation, and there were also many centers that were doing almost none. And so we weren't really comparing patients who got general anesthesia to patients who got conscious sedation. We were comparing almost centers that did conscious sedation versus centers that did general anesthesia. It's more sophisticated than that, but it's a technique that really does help isolate the effect. So I think the effect that I spoke of reducing mortality is real, not just an artifact, not just confounding. But let me turn it to David and Jung-Min to say who needs general anesthesia, or our other panelists as well.
Initially, general anesthesia may be the worst patient. in the initial period, but nowadays our anesthesiologists sometimes want to do the local anesthesia rather than general anesthesia in sicker patient, because general anesthesia, the recovery period is longer, and sometimes cannot recover from the general anesthesia after TAVI. So the in our current practice, in 1 year, general anesthesia is only 1 or 2 patients out of 200 patients. So I agree that it might be the selection bias, but now that we apply the cautious sedation instead of general anesthesia in almost all cases.
Okay, the meaning is actually, the between the general anesthesia conscious, local anesthesia, we do, separate the, complex still patients. If the meaning is David, David would, I would ask a very simple questions. You have, many aortic stenosis, symptomatic aortic stenosis in all patients. In our cases, anyway, we think about the TAVI first, right? However, still, there are some patients we don't like, TAVRs. Actually, we didn't think about the general anesthesia. However, we think about the send the patient to the surgery so far, right? And so, could you define what patients, what kind of patients you don't want to do TAVR? Almost all cases we can do that. However, we're going to define those patient groups, right?
I think that's incredibly wise words. And all the group in Vancouver, John, Anson, Jan very well.
I know.
So the pendulum swings and it swings back and it swings back, right? I mean, since 2005 in Vancouver, and then, thousands and thousands of cases. And I think we got to a point where we were probably doing everyone, like you said, with TAVI. And now we're a little bit more thoughtful that really patients, some patients just do better with surgery. I think to your point about who do we do with Minimalist, and Dave Cohen can attest to that. I think we've got to a very comfortable place, not just with our center, but again, working with more than 200 centers, many of them leading centers like yours around the world, where the vast majority of those cases are done awake, even the complex high-risk ones. And with regards to the ultrasound piece, the echo, I really think with modern heart team and a good CT ahead of time and a good echo ahead of time, the need for an on-table echo, other than we're dogmatic now about always getting an echo after the valves got in with on-table hemodynamics, because we really do think that's now crucial for future TAVI. But the need for an urgent transthoracic echo during the procedure, that's probably 1 in 300 cases now. And so it's not enough to change our workflow. But again, wise words, the pendulum swings. I'm sure in a few years we'll be talking about different things again. But right now, that's kind of where we've landed, at least in Vancouver and for many benchmarks.
And I do think there was definitely a concern early when we started to do conscious sedation and minimalist approaches that perhaps we were not doing as good a job with the implant because we didn't have the TEE to find the small areas of paravalvular regurgitation or things like that. But the studies, first of all, the general anesthesia study versus that we did in TBT, didn't show any compromise of the shorter or the longer term outcomes. And in the partner trial, we did a comparison of patients who got general anesthesia versus conscious sedation and looked very carefully at the follow-up echocardiograms with respect to paravalvular regurgitation gradients and all those things. And we couldn't identify any difference. And so I think the point about, that we can plan the procedures so well now that the role that echocardiography had when we first started doing it, where we needed it continuously, is much less frequent. We still need it from time to time, and it still is a very nice thing to have if we're doing a really challenging case for it. But those are the rarity, not the general case these days.
And the pipeline we're all going to get to play with not just Edwards, but all the platforms with commissural alignment and different techniques for sizing, so you don't sacrifice when you under or over expand, especially with balloon expandable. Really, the sky's the limit on what type of peri-procedural outcomes we're going to be able to achieve. It's pretty amazing.
Okay, great. I think it's time to close, and really thank you all for the nice lectures and excellent discussions. I hope everyone join this session. So hopefully Deb Cohen, Debbie Wood, you all getting meet together in the next years. Definitely face to face. We're gonna have some fun together. Right. Thank you. Thank you all.
Thank you.
That would be wonderful. Thank you.